Our topic for EMN5 today is going to be Ludwig's angina. So what is Ludwig's angina? I always was confused as a medical student with this one, angina being the equivalent of MI in my mind, and yet this had something to do with ENT. So as far as the name Ludwig's angina, angina actually comes from the name strangling. So you can see why that might be a name associated with MIs. And in this case, the strangling is because of the potentially life-threatening complication of airway compromise that can be associated with Ludwig's angina. So the definition is a cellulitis of the floor of the mouth. Think the submandibular space. And like I said, it's a potentially life-threatening infection. The major causes are dental, so any of the lower molars or gums. Make sure to ask your patients if they've had any infection within the recent weeks, and also been known to cause from piercings, like from the frenulum or the tongue. And you can see here that the submandibular space is comprised of the submylohyoid space and the sublingual space. And here's an example of a patient with Ludwig's angina from the Atlas of Emergency Medicine. There's a lot of fullness in the face here, so the submental area, and here on x-ray as well. So the symptoms you're going to see these patients come in with, fever, pretty toxic appearing, complaining of some dysphagia, difficulty swallowing. And then on your exam, you'll notice fullness and induration of the floor of the mouth that you can both feel from the inside, and also this fullness in the submandibular space on the outside as well. Sometimes you can even feel crepitus in that area. Patients will complain of a lot of pain, edema, feeling of kind of a full throat. Sometimes they can even feel closing airway. Further along in the spectrum, their voice might be kind of muffled. You might hear stridor or see them actually drooling, sitting forward. One thing to especially look for on exam is an elevation of the tongue. The tongue is going to be displaced superiorly and posteriorly. And you can see that that is why you get your airway compromised, and it can actually become obstructed in up to 33% of patients. That's huge. So the diagnosis is going to be a CT face and neck with IV contrast, as well as your clinical suspicion. Treatment, make sure you think of your ABCs, secure an airway right away if needed. Think about having a cric kit by the bedside and calling anesthesia if you think it's going to be a difficult airway. Have the patient sit upright, forward, however they feel comfortable, and as always in these situations, try to keep them calm. You want to be starting IV antibiotics and consider steroids as needed. Make sure you consult ENT, and this person is always going to the ICU because of the risk of airway compromise. As far as IV antibiotics, this is a polymicrobial infection. You have oral anaerobes and also some aerobes, such as strep and staph. So in a patient that is otherwise healthy, you can pick one of the following, either penicillin G plus Flagyl, you can do clindamycin, or Unicin. In an immunocompromised patient, you can pick one of the following listed here, so cefepime plus Flagyl, imipenem or meropenem, or Zosyn. The major complications that I already mentioned were airway obstruction. You can also have spread of the infection. It can go down, cause mediastinitis. You can have it go superiorly, causing intracranial infection, or even an IJ thrombophlebitis. So the three to remember for Ludwig's angina is, number one, what it is. It's a cellulitis of the submandibular space. The big deal about Ludwig's angina is that 30% of patients can have an airway obstruction. That's big. So to treat these patients, get ENT involved early, start your IV antibiotics, and make sure and protect that airway. Thanks again for joining us on EMN5.